Thank you for the invite. So to talk on urinary incontinence, obviously it's an area I'm passionate about. It's towards the end of the day, so I hope I can enthuse you regarding urinary incontinence today as well. Urinary incontinence has a number of different definitions, and these have been designed by the International Continence Society. They published a terminology paper, and these are the current terminologies used in practice today. Stress urinary incontinence is the involuntary leakage of urine with effort and exertion versus urgency incontinence, where involuntary urine leakage is associated immediately preceded by urgency. Most commonly we see, though, a mixture of the two, and you may have heard of the overactive bladder, which is urgency with or without urgency incontinence, and it's usually accompanied by frequency and nocturia. But first, if we're going to talk about problems with continence, normal bladder functioning. I'll talk in the next couple of slides about the physiology, but we recommend a normal fluid intake to be around 1.5 litres to 2 litres of ideally water per day. Bladder irritants include carbonated drinks, alcohol, caffeine, and even the tannins in tea can be irritating to the bladder. Normal voiding pattern is around 4 to 6 times a day and 0 to 1 time at night. Although a rule of thumb that I have is for someone over the age of 60, for every decade of their life, I add an extra trip to the bathroom at night as being acceptable. And I just included that picture there for some women with voiding dysfunction, adding a stool for them can be very beneficial for them with emptying their bladder. So this is a maturation cycle. Please don't sigh when I show this. I think it's really, really important that we have an idea in the background as to how the storage phase and the voiding phase occurs, because it has an implication regarding our medication that we're going to prescribe. So the storage phase involves the sympathetic nervous system, noradrenaline to the adrenergic receptors. They feed back during the filling phase. Stretch receptors then feed back to the pontine maturation centre, which then activates the parasympathetic nervous system. Release of acetylcholine to M3 muscarinic receptors on the detrusor muscle, causing contraction of your bladder and the voiding phase. It's very important that the likes of oxybutynin, which I'll talk about a little bit later, obviously that's going to have an impact on the parasympathetic nervous system to allow that relaxation of that bladder. But that's not the only thing affecting our ability to maintain our continence. And the intra-abdominal pressures placed on our little bladders also have a significant impact. Now, that intra-abdominal pressure can be from pelvic masses, from obesity, and I work at counties, so obviously that's a major problem for us, but a number of exercises can also have a major impact. When I have a patient in front of me and I'm looking at their pelvic floor function, I often have this graph in front of me, pelvic floor function versus the decades of one's life. And you can see there we reach the dizzy heights of our pelvic floor tone in the second decade of our life, and then you have inciting factors such as childbirth or pelvic floor trauma that could have an impact. However, unfortunately, there's a steady decline over age to at some point we'll cross that symptom threshold line, which you can see here. Now, for a patient on the line to A, they may not reach their symptoms till they hit their 70s. But for some of us, when we head towards the menopause and we perhaps increase our activity, that symptom threshold we'll notice in our 50s. And often the time where women start to notice pelvic floor dysfunction and urinary incontinence is when they hit the menopause and there's the hormonal influence taking place. So when you have a patient with urinary incontinence, it's important to take a very clear history. Identify the characteristics of their incontinence, its onset, its frequency, what are the precipitating events when they're coughing, when they're exercising, what's the environment that the patient is surrounded in. Is it an elderly, frail woman who's having to go to the bathroom many times at night? Is she at risk of having falls? Does she need a commode by her bed? Think about other environmental factors that could influence her management of her continence. Fluid intake we've talked about, and I've seen women who come to clinic with their overactive bladders and they're drinking 5 cans of V a day, or they're drinking 2 litres of Coke a day. These are patients that obviously education is the primary aim to improve their control. Medications and management of their comorbidities. I'll talk a little bit more shortly. So identifying the difference between, I'm going to mostly talk on stress incontinence and urgency incontinence. I'm not going to talk so much on overflow incontinence. But stress incontinence, usually someone experiences leakage with coughing, sneezing, running, jumping. However, with urgency incontinence, someone will complain of not making it to the bathroom. I call it a keyhole bladder. Often someone, when they put the key in the door when they make it home, that's when their bladder starts to contract. And often those women experience waking at night with the urgency. Remember the reversible causes with incontinence: delirium, infection, management of any medication concerns, excess fluid excretion, stool impaction are all easily managed. Having a global assessment: has someone got a chronic cough? What medications are they on? Have they got dependent edema that's steadily increasing through the day and they need to be raising their ankles in the evening or wearing compression stockings? Have they got vaginal atrophy present? I'm sorry about these next 2 busy slides, but I put them up just to remind us all about the medications that can have an impact on the bladder. Going back to the first couple of slides on the physiology, these all have an interaction, many of them on the nervous system, to cause either overactive bladder symptoms or potentially urinary retention. Antipsychotics are another one that can cause urinary retention, tricyclic antidepressants again, and hormone replacement therapy. Around the time of menopause, someone starting on hormone replacement can experience urinary stress incontinence or overactive bladder symptoms. So as part of the examination, investigation for urinary incontinence and examination, a bimanual examination and speculum examination, look for signs of a prolapse. Someone may present with overactive bladder symptoms, but actually they have an anterior wall prolapse that needs to be attended to. And I assess a prolapse on full Valsalva, and those women with a symptomatic prolapse at or beyond the introitus, please refer them to us for management of that. Look for signs of irritation, signs of atrophy. Can you give them a Vestin cream that may be beneficial? I also assess the pelvic floor muscle tone. After I've done a bimanual examination, making sure there's no pelvic masses, turn my fingers over and ask the patient to contract, and you'll feel the contraction on your between your fingers. And I do a cough stress test. A lot of patients they underreport how bad their incontinence is. And if you see when they give a cough when you're doing a pelvic examination and you see leakage, that patient has a significant impact to their life. It's important to do a urinalysis as part of the assessment and send it for a midstream urine if that comes back positive. And a bladder diary can be extremely useful. Referral for these various possibilities is also really important. A suspected pelvic mass, any signs of hematuria, either macroscopic or microscopic, needs referral. Any associated neurological problems or new fecal incontinence, have they got any signs of a fistula? Someone in acute urinary retention, or have they recently had previous continence surgery that we need to be dealing with if they've gone into retention? This is what a bladder diary may look like, with the types of fluids and the volumes passed. I expect to see a normal volume passed of between 200 and 400. So in this case, this woman's voiding 10 times a day with a couple of times at night. The volume's there, 50 mils, sometimes 20 mils. This is a classic picture of an overactive bladder. So stress incontinence, how will we manage that? Cough, sneeze, run, jump, and have their leakage. Lifestyle modifications are very, very important. Weight reduction if the BMI is greater than 30. Management of one's fluids and reducing the caffeine, carbonated and alcoholic drinks. Smoke cessation, trying to avoid heavy lifting, regular voiding patterns and bowel habit, treat any reversible causes, and try and optimise any medical conditions, whether it be a chronic cough or asthma. Pelvic floor exercises. A dedicated women's health physiotherapist is worth their weight in gold. They are a fantastic facility to improve pelvic floor, control pelvic floor tone. There's if I asked the room here for everybody to do a pelvic floor contraction, I would find about 50% of you actually did the pelvic floor contraction incorrectly. And the only way to really identify whether someone is performing a correct pelvic floor contraction is to assess it at the time of your bimanual examination. Take the opportunity when someone's having their smear test to just check that they're doing their pelvic floor exercises correctly. I see a number of women that actually do a Valsalva rather than a contraction. Pelvic Floor First is a great website to go to. So if you just Google Pelvic Floor First, it gives you some great pelvic floor friendly exercise regimes that can be helpful for women, especially a number of women attending the gym. Some exercises are beneficial, but there's a lot of exercises that can actually do damage to the pelvic floor. My other special interest is with postpartum perineal trauma, and I see a lot of women coming to boot camps within their first year after having a baby, and that pelvic floor is recovering over the first year after a baby, and boot camps within the first 6 weeks of their delivery or within the first year of their delivery can have a major impact on these women's pelvic floor. And I'm seeing women coming through with prolapses at a much younger age than what I used to 5-10 years ago. Other conservative options. Check with your patients that they're using the right continence pads. Menstrual pads are do not take away the urine from the skin and can cause a lot of irritation. So make sure your patients are using tenor or poise pads. Financially, pads can be a major problem for our patients, especially in counties Manukau, but obviously anywhere in the country. And a washable form of a liner is very, very useful. Comfortex push out you can see there a pair of continence underwear, and they can hold up to 150 mils of urine. So they cost about $30, but they're fantastic for management of women's continence. And I use ring pessaries with a little knob there that you can see. The knob just supports the bladder neck, and I teach women if they're in the childbearing age and they haven't completed their family, I don't like to perform surgery until they have completed their family, and the option of a ring pessary when they're exercising, when they're finding they have the most leakage, is a very good alternative. Out at Counties Manukau, I'm one of 2 urogynaecologists with Dr. Lindsay Hayward, and we obviously have quite a difficult time servicing South Auckland. So I have this questionnaire. It's on the HealthPoint website. If you go to the primary care management and referral guidelines for gynaecology outpatient, in the appendix section of that is this urogynaecology questionnaire. We put that there to try and be able to accurately grade patients coming into Counties Manukau in order to have the patients that were in the most trouble seen as soon as possible. So what are our surgical options if conservative measures have failed? 20 years ago, it was the Birch colpo suspension, open or laparoscopic. However, that's now changed over the last 20 years to the gold standard now being mid-urethral slings. Out at Counties, we use the tension-free vaginal tape, which is a retropubic sling, and the transobturator tape. However, we've found that the transobturator tape in larger women doesn't have the longevity of a tension-free vaginal tape, and so we tend to use the retropubic slings more. Guide your patients to patient pamphlets, which are on a website, www.iuga.org, so that's the International Urogynaecology Association. These are free to download and free to print. They're in a number of different languages, and they provide a very good resource for patients and for information regarding the surgery that they may be directed towards. Just want to very briefly talk about mid-urethral tapes. They're effective in 75 to 90% of cases. We've had over a couple of thousand research journal articles written on this procedure. It involves a dynamic kinking of the mid-urethra, and as you can see there, the tape is passed through the mid-urethra and back out suprapubically. It's not without its risks though, and other than with any pelvic surgery I do, infection, bleeding, injury to bowel and bladder, DVT risk, anaesthetic risks, specifically with the mid-urethral tape, there's a risk of unmasking urinary urgency. However, when women have mixed urinary incontinence, about 60% will have improvement of their overactive bladder symptoms with a mid-urethral sling. 5 to 15% will have worsening of their urgency, and about 20 to 30% will have persistence of their urgency. You can see there a little piece of mesh extrusion through the anterior wall of the vagina from a suburethral sling. This can happen over time, especially if the tape's placed perhaps premenopausally, the patient's gone through menopause, the vaginal skin has got thinner, and sometimes we see this. With the meshes that we're using now, they're a macroporous mesh. There's been a lot of development of the meshes over time, and obviously there's been a lot of problems with them. But very, very few cases of the current meshes are prone to infection. So I think it's important. I see the odd patient come back with mesh extrusion through the vagina. It's usually reasonably easily resolved by cutting the piece of mesh out, reclosing the anterior vaginal wall, and very little of them is actually infected, which I think is a good thing. So please send these patients, if you find when you do an examination, or if the patient complains of pain at any time after they've had a piece of mesh placed in their vagina, please refer them back to the gynecology service so that we can be managing them. Periurethral bulking is an option for those women who have had perhaps a mid-urethral sling for urinary stress incontinence. The urethra has been lacking in urethral hypermobility. They may have a possible intrinsic sphincter defect in that they have ongoing urinary stress incontinence. This bulking agent can be placed at the bladder neck. Unfortunately, though, the symptomatic relief for it is generally short-term. So for overactive bladder, this is someone who's got a rush to the bathroom, experiences urgency, frequency, nocturia. These are all symptoms that may have an underlying cause. Have they got some sort of little calculi sitting in their bladder causing irritation? Have they got estrogen deficiency? Have they got some other obstruction? Have they got a systemic condition? We talked about congestive heart failure, diabetes. Have they got a diabetic neuropathy having an impact on their bladder functioning? It may be the first sign of a possible neurological problem. So management of overactive bladder, perform a urine specimen, think about the contributing factors, exclude any anatomical cause with a renal ultrasound scan, pelvic ultrasound, treat any atrophy with estrogen cream. I have people ask me, what about someone with breast cancer, and giving them estrogen cream? It's a very difficult question, and I usually start with non-hormonal forms of moisturiser in the form of something like Replens. I like the patient to have a low risk of recurrence for their breast cancer and to not be on something like tamoxifen, and I'll always talk with their oncologist before starting estrogen cream. Even vaginally, it can still be a small amount as systemically absorbed. Send these patients to physiotherapy for bladder retraining, pelvic floor exercises, and consider starting an anticholinergic. That will be what the bladder retraining will be what's dealt with physio. They'll adjust their fluid intake. They'll recognise any trigger factors. Timing of one's voiding can be very beneficial. The medication I usually start with is oxybutynin. A frail elderly woman, I'll start them on 2.5 milligrams once or twice a day, slowly increasing the medication to a maximum dose of 5 milligrams 3 times a day, but treat a patient with the lowest dose. Obviously, one of the challenges with anticholinergics is compliance due to the side effect profile with dry eyes, dry mouth, constipation, and it's obviously contraindicated in narrow-angle glaucoma in patients with gastric retention. If someone has intolerable side effects with the oxybutynin, think about tolterodine or solifenazine as alternatives. There's a newer medication that's out in Australia, mirabegron. It's a beta-adrenoreceptor agonist, so it acts on the sympathetic nervous system, providing adding to the relaxation phase of that detrusor muscle, and it's an alternative to the antimuscarinics. It's not currently available in New Zealand, but hopefully with time we might see it here. So who needs Botox? Those that have failed conservative measures, usually we get confirmation of their overactive bladder symptoms with urodynamics. It's a day-stay procedure. Women get around 70% relief from their symptoms. However, it's transient. The symptom relief is only lasts for 6 to 9 months, and the procedure needs to be repeated. And there's a 10 to 30% chance of urinary retention. A frail elderly woman who may have eyesight problems may not be able to do the intermittent self-catheterising if they develop over that 2-week time frame the urinary retention. And so sometimes I'll put a suprapubic catheter in at the time of giving them Botox on a flip flow valve, so if they develop the urinary retention, it's easily resolved. This is how we place the intravesical Botox with 10 to 20 injections into the bladder. For refractory overactive bladder, there's options of percutaneous posterior nerve stimulation, sacral neuromodulation, augmentation cystoscopy, and bladder diversion, or placement of a suprapubic catheter. This is generally a multidisciplinary team setting with the urologists. So in conclusion, ask the question, dispel any myths, classify the types of urinary incontinence, identify any contributing factors, treat a urine infection, manage constipation, refer patients to a physiotherapist. They do a fantastic job with management of these patients. Treat any vaginal atrophy with Ovestin cream, treat any overactive bladder symptoms, and provide information, and refer to us if conservative measures fail. It's a multifaceted management of urinary incontinence, but every piece counts. Thank you very much for your attention.